Okay, just as Dr. Sundar talked about yesterday, one technique for all of entropion, I'm going to talk about one technique for all of ectropion today. And I think, always keep in mind the lower lid can be turned out, turned in, pulled down, rarely pushed up. And just as the forehead may affect what you do to the upper eyelid with regards to blepharoplasties, the midface may also affect what you do for the lower eyelid. With regards to lower lid malposition, I think, pay attention to a few things. First of all, horizontal laxity of the eyelid. Pay attention to the anterior lamella skin. Make sure the orbicularis muscle is functioning, is not weak. Look at the middle lamella, especially if patients have had previous eyelid surgery, and then the posterior lamella, look closely at the conjunctiva and tarsal plate. I think, though, the fundamental principle is that a tight lower lid is a stable lid, and there is this interplay between the anterior and posterior lamella. So when we look at lower lid ectropion, the two biggest ones are involutional and cicatricial. Although the books talk about paralytic ectropion, I really think that this is a retraction, and then rarely we'll see a mechanical ectropion. So lots of theories with regards to what causes lower lid involutional ectropion. Lower lid retractor disinsertion, lower lid laxity, orbicularis malfunction, tarsal plate size. So there's some thought that if you have a big tarsal plate, it's going to cause ectropion, and that's why we see it more in men than women. Lamellar dissociation, meaning that the anterior and posterior lamella have dissociated and aren't playing together the way they should. And then also axial globe position. So patients with involutional lower lid ectropion, what are we going to do for these guys? Well, first and foremost, I want to know if there's going to be horizontal lid laxity. In general, there should be. If there isn't, there's a problem. How do we test for this? We have two tests, a distraction test or a snap test. So in the distraction test, we pull it down and measure how far it distracts from the globe, differing measurements with regards to what people say is normal and abnormal. I've seen 6 millimeters as being one of the measurements. I probably do more of a snap test in the sense that almost every patient that I see in clinic, I'm going to pull on their lower lids. No matter what I'm going to do, I'm almost always going to pull their lower lid down, and I think that after you do that a few thousand times, you're going to know what's normal and abnormal. But if you pull the lower lids down and then let them go, if they don't snap back up against the globe, especially with one blink, then they're considered to be lax. How do we treat lower lid ectropion? Lubrication, maybe a lateral tarsal strip or a lateral canthopexy, maybe a medial spindle, maybe retractor reinsertion, inverting sutures, maybe look at the cheek as well. But usually it's going to be a combination of these two. But there is going to be one underlying theme to lower lid malposition repair, and I really think for me that's the lateral tarsal strip. I know that Dr. Sundar yesterday talked about the trans upper eyelid canthopexy. To me, a lateral tarsal strip is really the workhorse of the lower lid. As a beginning oculoplastic surgeon or general ophthalmologist, having the lateral tarsal strip in your toolbox I think is critical. And why do we do it? Well, really you're tightening the lower lid at the area of interest. The thought is that a lot of involutional lower lid laxity is due to laxity at the lateral canthal tendon. So you don't want to wedge good tarsus, you want to tighten it at the area that is abnormal. There's very little chance of notching, the scar is basically unnoticeable, and it corrects the anatomic problem. And as I said, a tight lid is a stable lid. Sometimes we'll put a little periosteal strip there if I need extra stabilization. So how do we do a lateral tarsal strip? We do a lateral canthotomy, inferior cantholysis. We fashion the slip, possibly shortening the strip, and then we fixate the strip. Always remember about globe position. So if a patient is relatively proptotic, then you want to place that canthus a little higher. If they're relatively have some relative inophthalmos, you don't want to place them too high, because if you do, that lid may stay that high. So as I said, canthotomy, cantholysis, formation of the strip. So let's look at this video here. So we did a lateral canthotomy, now I'm doing an inferior cantholysis, and then I'm going to fashion the strip. So I'm dissecting between the anterior and posterior lamella. I'm going to do that for, depending on how much tightening I need, usually 5 millimeters to 10 millimeters. I'm going to excise the mucocutaneous junction, and then I'm going to scrape the backside of the strip. I think a lot of this was described a long time ago. Whether you really need to scrape the backside of the lid or not is questionable. I'm going to see how much I will need to shorten it. And then I use a double arm 4-0 Merceline suture on an S2 needle, so that's a half circle needle. And lots of different sutures to use for this, but I like a half circle needle and I like it double arm so that I can engage the periosteum of the lateral orbital rim at the level of Whitnall's tubercle. And I place both of those sutures there, and then I'll tie them. Lots of different sutures to use. I think the one risk in using Merceline is that I think I have about a 1% suture granuloma rate, realistically, because I do a few hundred a year and I see probably a few hundred suture granulomas a year. As we talked about axial position of the globe, just be careful with that. So what other things might you do with it? Well, you might do a medial spindle. To me, this is a relatively weak procedure. It's good for a vertical punctum, but if there's more ectropion than that, I think it's not strong enough. So for a medial spindle, we're going to excise a little diamond-shaped piece of conjunctiva and lower lid retractors inferior to the inferior border of the tarsus, straddling the punctum, and then placing double-arm sutures. So here we are, we're using the Westcott scissors to excise, as I said, a diamond-shaped piece of conjunctiva and lower lid retractors. So this is really a lower lid retractor advancement medially. So I engage the lower lid retractors, then I engage the inferior border of the tarsus. This is a double-armed chromic suture. And then we're going to place these needles full thickness through the eyelid. The further down you go on the cheek, the more inversion you're going to get. But again, I think that this is a relatively weak procedure, so I wouldn't try to push it too hard. And what I mean by that is that if you have a total tarsal ectropion, I don't think you're going to get this with a medial spindle. And I'm almost always, I should say always, but almost always going to tighten the lid as well. So if I have more ectropion, I'm going to do inverting sutures. And so I'll do a little lateral canthopexy as well. I sort of call this 3-point fixation. So it's a lateral tarsal strip with inverting sutures with a lateral mini tarsorrhaphy to stabilize the lateral lower lid. So I'm using a cutting cautery here, canthotomy, cantholysis. Now I'm making a transconjunctival incision extending from the level of the punctum medially to the lateral canthus laterally. Again, you can do this whatever cutting instrument you want. I'm dissecting between the orbicularis muscle and the orbital septum to the inferior orbital rim. This sort of loosens up the anterior lamella. And now I'm going to place these inverting sutures, which are getting placed double-armed through the transcutaneous, through the skin and orbicularis muscle, about 1 centimeter inferior to the inferior border of the tarsus. I then engage the inferior border of the tarsus and then place the suture back through. So this sort of reassociates the anterior and posterior lamella. I place about 3 of those sutures, close my conjunctival incision. Now I'm going to do this little lateral mini tarsorrhaphy after the lateral tarsal strip. So the lateral tarsal strip is being placed, but right now I'm suturing the lateral upper and lower lid to give myself a tiny little tarsorrhaphy, and that just stabilizes me laterally and also tightens the upper lid a little bit. So here are these are patients that I think that if you tried to tighten the lower lid only, or if you did a medial spindle, I just don't think you're going to repair that amount of ectropion. So I think you need to do a little bit more than that. With regards to cheek and midface elevation, I'll do this in those patients that have maxillary hypoplasia, especially in those patients who have a little bit of tight skin, might have a component of cicatricial ectropion as well as involutional ectropion. With regards to cicatricial ectropion, this is due to a shortening of the anterior lamella, actinic damage, previous surgery, burns. So here's a typical burn patient with cicatricial ectropion. For me, I'm going to stabilize the posterior lamella again. I'm almost always going to do a lateral tarsal strip, and then I'm going to lengthen the anterior lamella, usually with a skin graft, but you could do a cheek lift as well. And so here's a patient before and after, burn patient again, before and after, full thickness skin graft to the lower lid. If I can do a cheek lift, I will, but for significant amounts of anterior lamellar shortening, you're not going to be able to do, but you will get a better cosmetic result if you do that. So remember, tight lid is a stable lower lid, and I really believe that lateral tarsal strip should be your procedure of choice alone or in combination with other procedures in treating lower lid malpositions. Thanks.